Hepatic encephalopathy is a neuropsychiatric syndrome which is caused by liver disease, and it most often results from high gut protein or acute metabolic stress such as gastrointestinal bleeding, infection, electrolyte abnormality, patient with pathosystemic shunting. As it progresses, confusion is followed by coma. Confusion needs to be differentiated from delirium tremens and Wernicke's encephalopathy and coma from subdural haematoma, which can occur in alcoholics after fall. Features of hepatic encephalopathy include change in intellect, a change in personality, emotions, and consciousness with or without neurological signs. There are two broad categories of hepatic encephalopathy, that's the covert hepatic encephalopathy and the overt hepatic encephalopathy. The covert is particularly associated with poor outcomes. Hepatic encephalopathy is also classified into three types based on the disease state of the liver. That is the type A hepatic encephalopathy, which is associated with acute liver failure. Type B is associated with pathosystemic bypass with no intrinsic hepatocellular disease, and type C is associated with cirrhosis and portal hypertension or pathosystemic shunts. Pathosystemic encephalopathy may occur in fulminant hepatitis caused by viruses, drugs, and toxins. It mostly occurs in cirrhosis or other chronic disorders when the extensive pathosystemic collaterals have developed as a result of portal hypertension. Encephalopathy also follows pathosystemic anastomosis, such as surgically created anastomosis connecting the portal vein and vena cava or the portal cava shunts, transjugular intrahepatic pathosystemic shunting, known as the TIPS. The degree of encephalopathy can be graded from grade 0 to grade 4, depending on the features, and is useful in assessing response to the therapy. When an episode develops acutely, a precipitating factor can be found, and the earliest features are very mild and easily overlooked, but as the condition becomes more severe, apathy, inability to concentrate, confusion, disorientation, drowsiness, slurring of speech, and eventually coma develops. Convulsions sometimes can occur in these patients. Examination usually shows a flapping tremor known as asterixis, inability to perform simple mental arithmetic tasks or to draw objects such as star, that's known as constrictional apraxia, and as the condition progresses, hyperreflexion and pyrethral extension plantar responses develop. Hepatic encephalopathy rarely causes focal neurologic signs, and if these are present, other causes must be sought. Fetal hepaticus or a sweetie mastoidea to the breast is usually present but more a sign of liver failure and pathosystemic shunting than the hepatic encephalopathy. Rarely, a chronic hepatic encephalopathy known as hepatocerebellar degeneration gives rise to variable combinations of cerebral dysfunction, Parkinsonian syndrome, spastic paraplegia, and dementia. We have the West Haven classification system for grading the symptoms. The grade 0, there is minimal hepatic encephalopathy, lack of detectable changes in personality or behavior, minimal changes in memory, concentration, intellectual function, and coordination, asterixis is absent. In grade 1, this trivial lack of awareness, shortened attention span, impaired addition or subtraction, hypersomnia, insomnia or inversion of the sleep pattern, euphoria, depression or irritability and mild confusion, slowing or inability to perform mental tasks. Grade 2, there is lethargy or apathy, disorientation, inappropriate behavior, slurred speech, obvious asterixis, drowsiness, lethargy, gross deficits and ability to perform mental tasks, obvious personality changes and inappropriate behavior and intermittent disorientation, usually regarding time. The grade 3, there is somnolence but can be aroused, unable to perform mental tasks, disorientation about time and place, and marked confusion, amnesia, occasionally fits of rage, and present but incomprehensible speech. Grade 4, there is coma with or without response to painful stimuli. Hepatic encephalopathy is thought to be due to disturbance of brain function provoked by circulating neurotoxins, which are normally metabolized by the liver. Most affected patients have evidence of liver failure and pathosystemic shunting of blood, but the balance between these varies from individual to individual. Some degree of liver failure is a key factor, as pathosystemic shunting of blood alone hardly ever causes encephalopathy. The neurotoxins causing encephalopathy are unknown, but they are thought to be mainly nitrogenous substances which are produced in the gut, at least in bats, by bacterial action. These substances are normally metabolized by the healthy liver and excluded from the systemic circulation. Ammonia has traditionally been considered as an important factor. The recent interest has focused on gamma-aminobutyric acid as a mediator, along with octopamine, amino acids, metacaptones, and fatty acids which act as neurotransmitters. The brain in cirrhosis may also be sensitized to other factors such as drugs which can precipitate hepatic encephalopathy. And the disruption of the function of the blood-brain barrier is a feature of acute hepatic failure and may lead to cerebral edema. The precipitating factors. In patients with chronic liver disease, acute episodes of encephalopathy are usually precipitated by reversible causes. And the most common causes are the following: metabolic stress, such as infection, electrolyte imbalance, especially hypokalemia, dehydration, use of diuretic drugs, disorders that increase gut protein such as gastrointestinal bleeding, high protein diet, and non-specific cerebral deplacement such as alcohol, sedatives, and analgesics. The diagnosis of hepatic encephalopathy can be made clinically, but when doubt exists, an electroencephalogram shows diffuse slowing of the normal alpha waves with eventual development of delta waves. The arterial ammonia is usually increased in patients with hepatic encephalopathy. However, increased concentration can occur in absence of clinical encephalopathy, rendering this investigation of little diagnostic value. The principle of treatment is to treat or remove precipitating causes and suppress the production of neurotoxins by bacteria in the bowel. The dietary protein restriction is rarely needed and is no longer recommended as a first-line treatment because it's unpalatable and can lead to worsening nutritional status in an already malnourished patients. Lactose at the dose of 15 to 30 milliliters 3 times a day is increased gradually until the bowels are moving twice daily, and this produces an osmotic laxative effect, reducing the pH of the colonic content, therefore limiting colonic ammonic absorption, and promotes the incorporation of nitrogen into the bacteria. Rivaroxaban 400 mg 3 times daily is a well-tolerated, non-absorbed antibiotic which acts by reducing the bacterial content of the bowel and has been shown to be effective. This rivaroxaban is usually preferred to neomycin, as neomycin is an aminoglycoside which can precipitate ototoxicity and nephrotoxicity. Rivaroxaban can also be used in addition or as an alternative to lactose if diarrhea becomes troublesome. Sedation-dependent encephalopathy should be avoided whenever possible. Chronic or refractory encephalopathy is one of the main indications for the liver in transplantations, and zinc supplementation is sometimes helpful.